Hello and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I'm Kim To. I'm the Assistant Professor of Digestive Disease at Yale University and the Associate Editor of the Social Media section with CLD. I'm joined by Dr. Neil Mehta, an Associate Professor from the Division of Gastroenterology and Hepatology at the University of California, San Francisco, to discuss his article in Liver Transplantation Criteria for HCC, including post-transplant management. Thank you for joining us.
Yeah, thanks for having me.
So can you tell us what are the main points you want our readers to get from this article?
Sure, absolutely. The main concept here is that liver transplant is an optimal treatment strategy for patients with early to intermediate stage hepatocellular carcinoma. I think that's been true for many years, but really in the last several years, what's really come about is less of a focus on tumor size and number or tumor burden, but really trying to focus on other kind of variables that really can affect selection criteria as well as post-transplant outcomes. So for example, there's been a lot of data about high alpha fetoprotein levels consistently being identified as a negative predictor of post-transplant outcomes. And so now nationally in most models throughout the world, there are AFP cutoffs by which if patients exceed those AFP values, they're not eligible for liver transplantation. But we're finding more and more such biomarkers, for example. So in the East, there's been a lot of data related to DCP and AFPL3, and we're seeing more and more of these types of variables that are biomarkers that are being included into different kind of selection criteria. The other, I think, main concept, and at least in the United States, is the concept of downstaging or kind of bridging local regional treatment. So as wait time is increasing, we're seeing almost all patients awaiting liver transplant now undergoing various types of local regional therapy to remain within transplant criteria, or currently the Milan criteria. We've extended that concept to actually patients who are beyond Milan criteria, who actually undergo such treatments like Y90 radioembolization or TACE, who are then downstaged into Milan criteria. And those patients are now actually eligible to receive automatic MELD exception after the mandatory 6-month waiting period.
And it's interesting, when we talk to our patients about post-management liver care after a transplant, I know you mentioned in your article about the retreat. Can you talk a little bit more about that?
Yeah, so absolutely. So the retreat score is a score that we developed maybe about 5 years ago in 2016 or so. That's been validated both in a multi-center as well as a national databases that incorporates 3 variables that we think are quite common and well-known and easy to kind of monitor variables that are related to recurrence risk. And so retreat is not a pre-transplant selection criteria. It actually involves explant data. And so it incorporates the alpha fetoprotein at the time of transplant, whether a patient does or does not have microvascular invasion, as well as the sum of the largest viable tumor diameter in the number of viable tumors on explant. So for example, if a patient had 4 viable tumors on explant and the largest was 4 centimeters, we'd combine them to 8. That would give them a certain number of retreat points, and then they'd get additional points based on their AFP and vascular invasion. That score, their retreat score, actually can stratify 5-year recurrence risk from less than 3% in patients with basically no risk factors, so low AFP, no microvascular invasion, and complete tumor necrosis on explant, all the way up to patients who with a retreat score of 5 or higher would have a 75% risk of recurrence within 5 years. We've also validated that this score predicts post-transplant survival as well, such that patients who have a retreat score of 0 have a greater than 90% 5-year survival, wow, versus patients who have a risk score of 5 or higher have a less than 60% 5-year post-transplant survival. So it really can be used once a patient undergoes transplant to understand their recurrence risk and their likely outcome. And then as we get more and more kind of adjuvant therapies to reduce post-transplant recurrent risk, maybe the retreat score can be used to identify patients at highest risk who might benefit from clinical trials or some of these adjuvant therapies.
Well, that's really actually very interesting and fascinating to use. I'm definitely going to be using that with my patients. Well,
Glad
thank
to
you
hear
again
that.
for joining us and making time for us for this interview. And thank you for our viewers for joining us for another installment in the Clinical Liver Disease video series. On behalf of all of us on the CLD team, I hope you found this interview interesting and very insightful, as well as I have. And for more information about our article, please visit www.cldlearning.com, and don't forget to follow us on Twitter at CLD Learning. And thanks again for watching.